Glandular fever, infectious mononucleosis, is an infection most commonly caused by the Epstein-Barr virus, EBV. EBV, also known as the human herpes virus 4, is one of the most common human viruses. It causes approximately 80 to 90% of cases of glandular fever, with the remainder due largely to cytomegalovirus, human herpes virus 6, toxoplasmosis, HIV, and adenovirus. Glandular fever is not particularly contagious. It is spread mainly through contact with saliva, usually from asymptomatic carriers, such as through kissing or sharing food and drink utensils. Small children may be infected by chewing toys that have been contaminated with the virus. It can also spread during sexual contact, through blood and semen, blood transfusions, organ transplantations, and by intrauterine transmission. The incubation period of glandular fever is about 4 to 7 weeks. The disease is contagious during the incubation period, and while symptoms are present, some people may be contagious for as long as 18 months after having the infection. Epstein-Barr virus, EBV, infection leads to a lifelong latent carrier state. The virus remains in the body lifelong. There is persistent low-grade replication, and the virus is shed intermittently into pharyngeal secretions, particularly saliva. These low concentrations of infectious virus account for the low to moderate contagiousness of the disease and the apparent requirement of intimate contact for disease transmission. Symptoms. Glandular fever is difficult to distinguish from other causes of sore throat, especially streptococcal sore throat. Suspect glandular fever if a person has fever, lymphadenopathy. Bilateral posterior cervical lymphadenopathy is typical. There may also be anterior cervical, submandibular, suboccipital, postauricular, epitrochlear, axillary, and inguinal lymphadenopathy. Lymph nodes are mildly tender and mobile. Sore throat, usually severe. There may be tonsillar enlargement. The tonsils may meet in the midline, and there is usually a whitewash exudate on the tonsils. Pharyngeal inflammation and palatal petechiae are also common. Petechiae are 1 to 2 megameters in diameter and occur in crops lasting 3-4 days. Sore throat may fail to improve or become worse after several days. Other clinical features that may support a diagnosis of glandular fever include prodromal symptoms. This usually lasts for several days and includes general malaise, fatigue, myalgia, chills, sweats, anorexia, and retroorbital headache. Nonspecific rash. This may be macular, petechial, urticarial, or erythema multiforme-like, or a maculopapular rash that presents after being treated with amoxicillin. Splenomegaly. The spleen reaches maximum size at the beginning of the second week of illness and regresses over 7-10 days. Hepatomegaly. Although more often there is mild tenderness in the right hypochondrium, I'll be aware that glandular fever is most common in people aged 15-24 years and is spread mainly through contact with saliva, such as through kissing or sharing food and drink utensils. In people older than 40 years of age, glandular fever is rare and may present atypically, without sore throat and lymphadenopathy in more than 50% of people, with unexplained fever of more than 2 weeks duration. Jaundice in about 20% of older adults. In a child under 3 years of age, infection with Epstein-Barr virus, EB, is usually asymptomatic, or the symptoms are indistinguishable from other childhood viral illnesses. The differential diagnosis of glandular fever includes other causes of sore throat, such as streptococcal sore throat. Lymphadenopathy is usually anterior cervical and submandibular, unlike with glandular fever, where posterior cervical lymphadenopathy is most common. Splenomegaly or hepatomegaly is not typical in adults. Fatigue is less prominent. Other causes of lymphadenopathy, such as local infection or inflammation, lymphoma or metastatic solid tumor. Leukemia rarely presents with lymphadenopathy. Other Other viral infections that may present with a glandular fever-like illness with an atypical lymphocytosis, such as cytomegalovirus primary infection, may present with splenomegaly, hepatomegaly, and a negative monospot test. Sore throat and lymphadenopathy are rare. Acute toxoplasmosis. Lymphocytosis is mild, but there may be hepatomegaly or splenomegaly. Acute viral hepatitis may cause malaise, fever, lymphadenopathy, and atypical lymphocytosis. Usually the lymphocytes are less than 10% of the total white cell count, and liver function tests are markedly elevated. Primary HIV infection may present with pharyngitis, fever, and lymphadenopathy, rash, diarrhea, weight loss, nausea, and vomiting. Mononucleosis-like illness is an HIV indicator condition. Rubella may rarely present with fever, lymphadenopathy, and atypical lymphocytosis. Rosola, human herpes virus -6 primary infection, is usually mild with a modest atypical lymphocytosis. Mumps typically presents with parotitis, and there may be low-grade fever and malaise. Herpes simplex virus 1 typically presents with acute onset of symptoms and high fever with myalgia, arthralgia, and cough. Symptoms typically last less than 2 weeks. Posterior cervical lymphadenopathy is absent. In children younger than 12 years of age, and in people who are immunocompromised at any age, arrange blood tests for Epstein-Barr virus, EBV, viral serology after the person has been ill for at least 7 days. In children older than 12 years of age, and in immunocompetent adults, arrange a full blood count, FBC, with differential white cell count and a monospot test, heterophile antibodies, in the second week of the illness. Glandular fever is likely if the monospot test is positive or the FBC has more than 20% atypical or reactive lymphocytes, or more than 10% atypical lymphocytes and the lymphocyte count is more than 50% of the total white cell count. If the monospot test is negative and not supportive of infectious mononucleosis due to EBV, repeat the test in 5 to 7 days. If the person has clinical features of glandular fever and a negative monospot test, or if a rapid diagnosis is needed, for example, if an urgent return to contact sports is desired. Arrange blood tests for EBV viral serology. If a second monospot test is negative, consider testing for cytomegalovirus and toxoplasmosis if the person is pregnant or immunocompromised. Consider testing for HIV. Consider checking liver function tests. Usually aspartate aminotransferase and alanine aminotransferase ALT are elevated to 2-3 times the upper limit of normal. Other investigations. FBC, raised white cell count with lymphocytosis, and a relative atypical lymphocyte count greater than 20%. Thrombocytopenia may occur. The ESR is elevated in most patients with infectious mononucleosis, but is not elevated with group streptococcal pharyngitis. Mild elevation of the serum transaminases, higher increases in serum transaminase levels suggest viral hepatitis. Throat swabs. Growth of group streptococci does not identify the cause of the pharyngitis. 30% of patients with infectious mononucleosis have group streptococcus in the oropharynx. Abdominal ultrasound may be required to assess for splenomegaly. EBV infectious mononucleosis can be diagnosed using a variety of unrelated non-EBV heterophile antibodies and specific EBV antibodies. Heterophile antibodies. Following infectious mononucleosis caused by EBV, 70 to 90% of patients produce infectious mononucleosis heterophile antibodies, antibodies against an antigen produced in one species that react against antigens from other species. The heterophile antibodies are not specific for the virus. These antibodies can be detected by Paul Buntle test. Sheep red blood cells agglutinate in the presence of heterophile antibodies. Monospot test. Horse red blood cells agglutinate on exposure to heterophile antibodies. Sensitivity and specificity for monospot are 70 to 90% and 100% respectively. Positivity increases during the first 6 weeks of the illness, and so the heterophile antibody test results may be negative early in the course of EBV infectious mononucleosis. The titer does not correlate with the severity of the disease. Agglutinins usually remain in the blood for 4 to 8 weeks, but may remain positive in low levels for up to 1 year. False positive results, although virtual 100% specificity exists with the monospot test. Other disorders may rarely produce a false positive result. Infection, e.g., toxoplasmosis, rubella, CMV, HIV, herpes simplex virus, malaria, viral hepatitis. Malignancy, e.g., lymphomas, particularly Burkitt's lymphoma, leukemias, cancer of the pancreas, connective tissue diseases, e.g., rheumatoid arthritis, systemic lupus erythematosus. False negative results may occur if testing is performed too early in the course of the illness. The false negative rate is as high as 25% in the first week of infection, 5–10% in the second week, and 5% in the third week of infection. Heterophile antibody tests are less sensitive in patients aged younger than 10 years. False negative results are particularly common in children aged younger than 2 years. 40% of children aged 4 years or younger do not have detectable heterophile antibodies at any time during EBV infection. EBV-specific antibodies. Patients who remain heterophile negative after 6 weeks with a mononucleosis illness are considered to be heterophile negative infectious mononucleosis and should be tested for EBV-specific antibodies. EBV-specific antibody tests may also be useful if a false positive heterophile antibody test result is suspected. Patients who are heterophile positive but specific antibody negative should be considered for testing for possible causes of false positive heterophile antibodies. The antibody response to specific EBV serological testing consists of measuring the antibody response to surface and core EBV viral proteins. The most useful EBV-specific antibodies are the viral capsid antigens, VCAs, and the EBV nuclear antigen, EBNA. There is a high agreement between the heterophile antibody tests and the VC-IgM ELISA, but the VC-IgM ELISA is more sensitive. IgM antibodies directed against the VCA of EBV are useful in differentiating recent infection from previous infection. Following acute infection, the increase in IgM levels peaks after 4 to 8 weeks, and IgM usually remains positive for as long as 1 year. Antibodies to EBNA are usually not detectable until 6 to 8 weeks after the onset of symptoms, but can help to establish whether infection is recent. EB, IgG, VCA antibodies rise later than the IgM VCA antibodies, but remain elevated with variable titers for life. Persistent IgG does not indicate chronic infectious mononucleosis and is not relevant in the assessment of chronic fatigue syndrome. False positive VCA antibody titer results may occur with other herpes viruses, e.g., CMV, or with unrelated organisms. However, false positive cross-reactivity to specific EBV antibodies is very rare. There may be false negative results early in the course of the infection and in young children, age less than 2 years. Complications of glandular fever include hepatitis. Common and self-limiting early complication of glandular fever. Fulminant hepatitis may rarely occur and can be life-threatening. Upper airways obstruction. This may be due to gross enlargement of the tonsils or a peritonsillar abscess, quinsy. Cardiac complications. Pericarditis, myocarditis, and cardiac conduction abnormalities have been reported in people with glandular fever. Renal complications. Interstitial nephritis, myositis-associated acute kidney injury, hemolytic uremic syndrome, and jaundice-associated nephropathy have rarely been reported in people with acute symptomatic glandular fever. Neurological complications. Encephalitis occurs in about 1% of adolescents and adults with glandular fever, usually during the first 2 weeks of infection. Other possible neurological complications include aseptic meningitis, facial nerve palsy, transverse myelitis, Guillain-Barré syndrome, and optic neuritis. Hematological complications. Mild thrombocytopenia has been reported in 25 to 50% of people with glandular fever, and autoimmune hemolytic anemia in 3% of people. Mild neutropenia is common and self-limiting. Rarely, severe neutropenia may cause neutropenic sepsis, pneumonia, or death. Splenic rupture. This is rare, less than 1% of cases, and usually occurs in the first 3 weeks of the acute illness. About 50% of cases of splenic rupture are spontaneous, and 50% follow trauma, which may be minimal. People with glandular fever are advised to avoid heavy lifting and contact or collision sports for the first month of the illness to reduce the risk of splenic rupture, after which these activities can be resumed, provided the person has no ongoing features of acute EBV infection. Chronic fatigue. About 10% of people with glandular fever will experience prolonged fatigue, lasting for several months after the initial infection. Most people with persistent fatigue recover within 2 years. Cancer. Association between glandular fever and lymphoproliferative cancers, especially Hodgkin's lymphoma and Burkitt lymphoma, are well established. Multiple sclerosis. Glandular fever as a risk factor for multiple sclerosis has been documented and may be linked to genetic susceptibility. Chronic active Epstein-Barr virus, EBV, infection. A very rare condition characterized by severe, chronic, or recurrent infectious mononucleosis-like symptoms after a well-documented primary infection with EBV in a previously healthy person. Chronic active EBV infection is occasionally associated with the development of lymphoma. Abnormal liver function tests. LFTs are abnormal in about 90% of people with glandular fever, with aspartate aminotransferase and alanine aminotransferase being elevated to 2-3 times the upper limit of normal. The increase in LFTs typically peaks in the second week of the illness and then normalizes over the next 3 to 4 weeks. Associated diseases. EBV is also associated with Burkitt's lymphoma, B-cell lymphomas in patients with immunosuppression, undifferentiated carcinomas e.g., cancer of the nasopharynx and cancer of the salivary glands, Duncan syndrome, rare, X-linked recessive, defective T cells fail to destroy the infected cells, associated development of autoimmune disease and lymphoma, multiple sclerosis. In most people, glandular fever is self-limiting and lasts 2 to 4 weeks. Occasionally, the disease course can be prolonged, lasting for weeks or months. Serious complications are rare and include upper airways obstruction, splenic rupture, and neutropenia. In immunocompromised people, EBV infection may result in malignant disease, such as Hodgkin's lymphoma and nasopharyngeal carcinoma. Fatigue is common and usually lasts for a few weeks, or for several months in a minority of people, about 10%. Epstein-Barr virus, EBV, infection leads to a lifelong latent carrier state. The virus remains in the body lifelong. The virus may reactivate but does not always cause symptoms. People who are immunocompromised are more likely to develop symptoms if EBV reactivates. Management of infectious mononucleosis. Arrange hospital admission if the person has a stridor, dehydration or difficulty swallowing fluids, a suspected potentially serious complication of glandular fever, such as splenic rupture. If hospital admission is not indicated, advise on the use of paracetamol or ibuprofen to relieve pain and fever symptoms. No specific antiviral therapy is available. There's been interest in the use of antivirals such as acyclovir and valacyclovir in the treatment of infectious mononucleosis, but to date trials have been unpromising. There is insufficient evidence to recommend steroid treatment for symptom control in infectious mononucleosis. Short courses of corticosteroids are beneficial for hemolytic anemia, central nervous system involvement, or extreme tonsillar enlargement. Ampicillin and amoxicillin cause an itchy maculopapular rash and should not be given in any patient who might have infectious mononucleosis. Surgery is usually advocated for spontaneous splenic rupture. One study of military personnel suggested a role for vitamin D in shortening recovery times in patients with acute pharyngitis associated with infectious mononucleosis. Explain the expected course of the illness. Advise that symptoms usually last for 2 to 4 weeks. Tiredness is common and is often the last symptom to resolve. Exclusion from work or school is not necessary. To return to normal activities as soon as possible. If they are tired, they should tailor their activities to what they can manage comfortably. Bed rest is not normally needed. To limit spread of the disease by avoiding kissing and sharing, eating or drinking utensils, and to thoroughly clean all items that may have been contaminated by saliva. To avoid heavy lifting and contact or collision sports for the first month of the illness. To reduce the risk of splenic rupture. Provide written information on glandular fever. Seek urgent medical advice if they develop stridor or respiratory difficulty, have difficulty swallowing fluids or have signs of dehydration, such as reduced urine output, become systemically very unwell, develop abdominal pain, may indicate splenic rupture. If a person has ongoing fatigue,